الرحمن الرحيم. هنبتدي بإذن الله السيشن اوف اندوكراين سيرجري. هنبتدي معانا الدكتور فادي هاني، هيكلمنا على البرزيستنت اور ريكارنت سيمبتومز افتر باراثايرويدكتومي. اتفضل يا دكتور هاني، 15 minutes.
Okay, good evening. I'm Fadi Hani, General Surgery Lecturer, part of Endocrine Surgery Unit, and I'm going to talk about persistent and recurrent symptoms after parathyroidectomy. Primary hyperparathyroidism is the third most common endocrinological disease after diabetes mellitus and thyroid disease, and it affects about 0.25 to 0.66% of population. Primary hyperparathyroidism is the most common cause of hypercalcemia, and its only curative treatment is surgery. The success rate of parathyroidectomy is above 95% in experienced centers, independent from preoperative localization methods and surgical technique. Persistent disease rate is reported in between 2 and 22, and the recurrent disease rate is reported in between 1 and 15% in literature. As a reminder, definition of surgical cure after parathyroidectomy is providing re-establishment of normal calcium homeostasis after surgery for at least 6 months. In normocalcemic primary hyperparathyroidism, the definition of cure is normal parathyroid hormone level together with normal calcium level for 6 months after operation. Definition of persistent hyperparathyroidism is the persistence of hypercalcemia or reappearance of hypercalcemia within the first 6 months after parathyroidectomy. In general, persistent hyperparathyroidism is related to the missed pathological parathyroid gland or incomplete resection of hyperfunctional parathyroid tissue. And the definition of recurrent hyperparathyroidism is the recurrence of hypercalcemia after a normal calcemic period of more than 6 months. Causes of persistent hyperparathyroidism, it includes inexperience of the pathogen, ectopic localization, supernumerary parathyroid adenoma, incomplete parathyroid adenoma excision, multiple gland disease, inappropriate resection of multiple gland disease, normocalcemic hyperparathyroidism, inappropriate double adenoma resection, and inappropriate resection of parathyroid cancer. For the recurrent hyperparathyroidism, causes include multiple gland disease, inappropriate resection of multiple gland disease, recurrence from remnant after subtotal resection, total parathyroidectomy and autotransplantation, recurrence from supernumerary gland, parathyroid cancer, and parathyromatosis. For a long-term follow-up for recurrence, in a meta-analysis including 14 studies, which have at least 50 patients and more than 1 year follow-up, the cure rate was determined as 96.9%, and the recurrence rate was 1.6% for 33 months mean. In recent studies, it is noteworthy that the recurrence rate increases with long-term follow-up. The recurrence rate of approximately...
لو سمحت ثانية.
Sorry.
لو سمحتوا يا ساد يا دكاترة اللي ورا، لو سمحت ادونا فرصة نسمع السبيكر لو سمحت.
A recurrence rate of approximately 10% was reported in 2 studies with mean follow-up of 3 and 5 years. So, as the follow-up period increases, the incidence of recurrence increases. In the literature review discussed at the 5th International Multidisciplinary Workshop on Primary Hyperparathyroidism, the discussion about the 6-month time period in the definition of persistent and recurrent disease is increasing, and it is recommended to update these periods and definitions, although the definition of recurrent hyperparathyroidism is development of hypercalcemia after 6 months of normocalcemic period. The main question is whether occurring of a new disease as recurrent hyperparathyroidism after this period, or this period is a transient period which masks the persistent hyperparathyroidism. For the verification of persistence of or recurrence, the biochemical diagnosis of persistent hyperparathyroidism and recurrent hyperparathyroidism is the same as the initial primary hyperparathyroidism. Specifically, it is characterized by hypercalcemia with elevated or insufficiently suppressed parathyroid hormone level. For the surgical indications for persistent hyperparathyroidism and recurrent hyperparathyroidism. Surgical indications for persistent and recurrent hyperparathyroidism are not different from the surgical indications for primary hyperparathyroidism. These patients have undergone unsuccessful parathyroid surgery compared to patients who will undergo primary surgery and are at increased potential risk due to secondary procedure. Parathyroidectomy is an option for all patients with the agreement of patient and physician and in the absence of any contraindication. The fact that primary surgery has been performed on an asymptomatic patient who does not have any specific recommendation in the guidelines does not mean that it is in need or indication for routine reoperation of persistent hyperparathyroidism if developed. The risk of complication secondary to reoperation is markedly high, with up to 10% permanent recurrent laryngeal nerve paralysis and up to 20% permanent hypoparathyroidism reported. So asymptomatic mild hypercalcemia is better than permanent hypocalcemia and permanent recurrent laryngeal nerve paralysis. Therefore, reoperation surgery is not required for every patient. The threshold for reoperation surgery should be higher than the initial surgery. For this, the severity of the disease should be evaluated quantitatively. Baseline assessment of the degree of hypercalcemia, such as calcium level above 12 milligram per deciliter, may be complemented by assessment of renal function, renal imaging, somatic symptoms, bone health assessment, and cardiovascular risk assessment. For evaluation of preoperative, intraoperative, and postoperative data, localization studies of the patients before the first operation should be carefully re-examined. Operative notes, if any, operative drawings, intraoperative parathyroid hormone results, pathological results, and the postoperative biochemical results should be reviewed. The surgical report of an experienced parathyroid surgeon performing the initial surgery is important. However, in an inexperienced surgeon performing the first operation, the pathology report is more important than the operation report. The type of surgery performed, lateral or central approach, focused surgery, unilateral exploration, and bilateral neck exploration, which parathyroid glands were identified, which parathyroids were removed, whether biopsy was taken from the parathyroid scene, and whether the left parathyroids were marked with clips or sutures should be evaluated in the surgical report. It should be evaluated how many parathyroid glands are removed in the pathology report, whether these glands are normal or pathological, and whether the glands from which biopsy was taken are parathyroid. If necessary, the remaining tissues from the previous pathological examination can be re-evaluated. It may be useful to evaluate preoperative localization studies and intraoperative findings together. These reports may contribute to estimating the number of normally vascularized parathyroid glands in the surgical area, the overlooked parathyroid gland and its probable location, depending on whether there is a pathological gland removed, whether there is a normal parathyroid gland removed or not. Preoperative vocal cords examination. Vocal cord paralysis due to initial parathyroidectomy may be symptomatic or asymptomatic. If the patient has preoperative vocal cord paralysis, it will have a significant impact on the surgical plan. If vocal cord paralysis is on the side on which reoperation is planned, perhaps the patient is exposed to little or no additional risk of adverse effects on the voice with reoperation. However, if surgery is going to be performed on the opposite side of paralysis, the functional mobile single vocal cord will be at risk. In this case, the indication for surgery should be reconsidered. If surgery is indicated, the patient is at risk of postoperative bilateral vocal cord paralysis that may require tracheostomy. This possibility should be discussed widely with the patient, and full and written informed consent should be obtained. Furthermore, other medical alternatives should be discussed with the patient as calcium mimetics and bisphosphonates. For the localization studies, we have non-invasive and invasive. For the non-invasive, localization studies with preoperative imaging methods should be performed in patients with persistent and recurrent hyperparathyroidism, in all patients with a confirmed diagnosis and surgical indications. Ultrasonography should be applied at the first-line imaging modality in persistent and recurrent hyperparathyroidism. Parathyroid adenoma missed by the previous ultrasonography specialist can be detected at second imaging. Although ultrasonography is a high operator-dependent modality, it is an inexpensive, accessible, and radiation-free modality. Thyroid lesions can also be evaluated together with the suspected parathyroid lesions. If necessary, it allows fine needle aspiration biopsy to be performed from both the suspected parathyroid and the thyroid gland. Ultrasonography often fails to localize adenomatous glands or localize ectopically located glands in obese patients. System-EB scintigraphy, it is frequently used methods for imaging abnormal parathyroid gland and is one of the first-line imaging methods in persistent and recurrent hyperparathyroidism. The most commonly used protocol includes the dual-phase method using System-EB labeled with technetium-99. The technique is combined with single photon emission computed tomography SPECT and hybrid imaging with both SPECT and computed tomography SPECT CT to increase sensitivity by providing additional anatomical imaging. To evaluate ectopic parathyroid glands, imaging should be below the aortic arch. Four-dimensional CT Four-dimensional CT consists of multiple slides, multi-phase CT, which often uses non-contrast arterial and delayed venous phase to detect changes in enhancement over time. Parathyroid adenomas show lower attenuation than normal thyroid tissue on non-contrast images, peak increase in arterial phase, and wash out in delayed phase. For the dynamic 4D magnetic resonance imaging, MRI is a modality that can sometimes be used in case of negative or incompatible primary imaging modalities, or in preoperative localization in persistent and recurrent hyperparathyroidism. Sensitivity of conventional MRI is similar to the ultrasonography and MIBI scan. Today, dynamic 4D MRI methods similar to dynamic CT are used as the second stage examination. Positron emission tomography, PET and PET-CT. PET is an advanced nuclear medicine imaging method that provides functional and metabolic information with high-quality imaging. PET-CT is combined with CT images to improve anatomical localization. PET imaging has improved sensitivity and spatial resolution over SPECT imaging. PET can also detect a very small pathological gland, providing better accuracy and clear images with faster acquisition compared to SPECT. For localization studies with invasive techniques, they include invasive examination can be performed when suspicious inconsistent results are obtained in non-invasive imaging methods, or in patients where no pathological lesion can be detected. Nowadays, invasive examinations are rarely needed in parallel with the development of non-invasive imaging methods. They include parathormone measurement with bilateral jugular vein sampling, parathyroid arteriography, finally the aspiration biopsy with guidance of imaging studies. So, as a summary, the threshold for reoperation surgery for persistent and recurrent hyperparathyroidism should be higher than for the initial surgery. In the preoperative evaluation, the initial diagnosis of primary hyperparathyroidism and the diagnosis of persistent and recurrent hyperparathyroidism should be confirmed in patients who are evaluated with a pre-diagnosis suspect of persistent and recurrent hyperparathyroidism. Localization studies with preoperative imaging methods should be performed in all patients with persistent and recurrent hyperparathyroidism with a confirmed diagnosis and surgical indications. Invasive examinations can rarely be performed in patients in whom suspicious, incompatible, or pathological lesions cannot be detected in non-invasive imaging methods. These are some operations of parathyroid gland resection. For primary hyperparathyroidism, they are most of them are parathyroid adenomas. This operation was operated by Professor Mahmoud al-Shafai with its system MIBI scan. This one is operated by Professor Wafi Fouad, and this operation operated by Professor Rami Mikhail. These are my references. Thank you so much.
هنستأذن حضراتكم خلي الدسكشن بعد كل السبيكرز بإذن الله. اتفضل.
السلام عليكم، ازيكم جميعا. First of all
هنقدم دلوقتي موضوع different approaches for adrenalectomy and the cortical sparing adrenalectomy هيقدمها الدكتور مصطفى ناجي مدرس جراحة طب عين شمس. اتفضل يا دكتور مصطفى.
السلام عليكم، ازيكم جميعا. First of all, I would like to show my deep gratitude for my dear professors for such a great opportunity. We will talk about the most common adrenal disorders, then our experience in endocrine surgery unit, then the new techniques for adrenalectomy. As we all know, hyperaldosteronism and oversecretion of aldosterone hormone from the zona glomerulosa. The most common etiology is bilateral adrenal hyperplasia followed by aldosterone-producing adenomas. The clinical picture, the patients present by hypertension, muscle weakness and fatigue, and polyuria and polydipsia. For the evaluation, the patient will undergo biochemical evaluation for the diagnosis of the hyperaldosteronism, and this is done by measuring plasma aldosterone concentration over plasma renin activity. If it's more than 30, it is diagnostic for hyperaldosteronism. Then the patient will undergo the radiological investigation for localization and lateralization. If the patient is localized by pelvic abdominal CT scan, he will go for the surgery. If the CT scan failed to localize, the patient will undergo adrenal venous sampling for lateralization, followed by the surgery. Then we will shift for Cushing syndrome, which occurs due to high levels of glucocorticoids. The most common etiology is exogenous steroids, followed by the STH-dependent, which may be due to pituitary adenoma or ectopic STH syndrome. May be non-STH-dependent due to adrenocortical adenoma or carcinoma. The patient will be presented by fat redistribution, moony face, buffalo hump. He may also present by facial plethora, red striation, ecchymosis, and hypertension, volume expansion with edema. Also, he might have peptic ulcer, diabetes mellitus, hypothyroidism, and sexual disorders. Also, the patient may present by proximal muscle weakness, osteoporosis, and bone pain. And for confirming the diagnosis, as we mentioned, we should start by biochemical evaluation for confirming the diagnosis, which is done by measuring 11 ppm salivary cortisol or low-dose dexamethasone suppression test. This is for confirming the diagnosis of Cushing syndrome. Then we will measure the STH to determine whether it is STH non-dependable or STH dependable. If it is STH non-dependable, so the patient will undergo CT scan for localization and lateralization of the tumor. If it is high level of STH and it is STH dependent, so the patient will undergo high dose dexamethasone suppression test. If it is suppressed, so the origin is a pituitary adenoma and the patient will undergo transsphenoidal surgery. If it's STH non-dependable, so it's mostly paraneoplastic syndrome and the patient will undergo localization by PAN-CT followed by resection of the tumor. Pheochromocytoma, which is a chromaffin catecholamine secreting tumors, either from the medulla or extraadrenal paraganglioma. It may be sporadic or familial. The patient presents by hypertension, hyperglycemia, attacks of sympathetic overactivity, panic attacks, tachycardia. The patient also may have cardiac manifestation such as hypertrophic cardiomyopathy, supraventricular arrhythmias, and premature ventricular contraction. Also, if there is an associated multiple endocrine neoplasia symptom, it will be present. For localization, it's not clear here. The patient will undergo first a biochemical evaluation for confirming the diagnosis by measuring plasma free metanephrin. Then the patient will undergo localization and lateralization by MRI pelvic abdomen. If it is failed in localization, the patient will undergo myopic scan followed by the surgery. Incidentlinoma, which is an incidentally discovered adrenal mass through imaging performed for non-related non-adrenal disease, and the existing is keeping high due to the advances in the radiological investigation. The most common cause is a non-functioning adenoma, followed by myelolipoma and functioning pheochromocytoma. For the workup, the patient undergo first a biochemical evaluation to diagnose and to determine either this incidentilloma is functioning or not. Then the patient will undergo the radiological features to determine the malignant potential. And is mentioned here in this scheme, if the tumor, if the incidentilloma is less than 4 centimeters, non-functioning with benign features, the patient will undergo regular follow-up. If it is of any size and functioning, the patient will undergo the proper preoperative preparation followed by surgical resection. If it is more than 4 centimeters and have a malignant features, the patient will undergo surgical resection. The only exception for the rule of 4 centimeters is myelolipoma. Up to 10 centimeters, it will be conserved and follow up and will undergo resection if it's large or symptomatic. The most common indication for unilateral adrenalectomy is Cushing syndrome, unilateral pheochromocytoma, virilizing tumor, unilateral non-functioning tumor more than 4 centimeters. And the most common indication for bilateral adrenalectomy is bilateral pheochromocytoma, bilateral nodular adrenal hyperplasia. The different approaches for adrenalectomy, it may be posterior approach through lumbar approach, thoraco-abdominal from the bed of 10th rib, anterior approach especially for bilateral exposure. And the standard of care in our unit, which is laparoscopic adrenalectomy. It is best for tumors less than 5 centimeters, and some suggest there is no upper limit in the hands of experienced surgeons. In our experience, it has been successful up to 12 centimeter tumor. It is a single center experience at laparoscopic adrenalectomy, a retrospective analysis from Jan 2020 till December 2023. 42 cases underwent a lab adrenalectomy at Ain Shams University Hospital. 20 cases were in the right side and 22 on the left side. 27 patients had functioning adenoma and 15 patients had non-functioning adenoma more than 5 centimeters. Laparoscopic technique is the preferred in our department due to increased practice and increase the learning curve of our surgeons. And in our experience, it has been up to 12 centimeters. Preoperatively, all the patient underwent the proper full hormone assay. They underwent the MRI abdomen. One patient underwent PET-CT for suspected bladder metastasis. Intraoperatively, 42 patients underwent lab adrenalectomy, 17 of them more than 5 centimeters. 3 patients were converted to open due to excessive bleeding, and the mean operative time was 76 minutes. Post-operatively, all the 42 patients were admitted to ICU for 1 day. The average hospital stay was 3 days and 6 days for those who were converted to open, and there is no mortality in our experience. The new evolving techniques for adrenalectomy will begin by robotic-assisted adrenalectomy, either transabdominal or retroperitoneal adrenalectomy, especially in the retroperitoneal appendectomy, adrenalectomy, as it needs a high sharpened angled instruments. For a single-axis retroperitoneoscopic adrenalectomy, it is require high surgical expertise with a longer mean operative time. And laparoscopic partial adrenalectomy or cortical sparing adrenalectomy is indicated in a small tumor less than 3 centimeters, peripherally located, not close or over the adrenal vein to preserve it, for bilateral penile tumors or unilateral. The tumor is excised with 0.5 centimeter safety margin, and the dissection is done using harmonic scale, and the adrenal vein can be preserved. The complication from this technique may be bleeding, tumor spillage, and recurrence even in benign lesions. The take-home message: laparoscopic adrenalectomy is the preferred technique with experienced endocrine surgeon with less morbidity and better outcome. Laparoscopic adrenalectomy can be done for large tumor with experienced surgeon. And thank you very much.
احنا زي ما قلنا الديسكشن باذن الله هتبقى افتر برزنتيشنز. دلوقتي هنعمل papillary thyroid carcinoma controversial completion thyroidectomy in low risk cases، وهيقدمها لنا الدكتور مارك مدحت.
Thank you, dear professors and colleagues. I'm honored to be standing in front of you today. Today, we'll try to briefly tackle all the controversies in papillary thyroid carcinoma. First of all, why is our topic important? Because when we talk about thyroid cancer, we're talking about the most common endocrine malignancy. Thyroid cancer is present in 7 to 15% of all thyroid nodules. Its incidence has tripled in the past 2 decades, becoming 2.1% of all new cancer cases worldwide. And this is said to be an epidemic of diagnosis rather than an epidemic of disease, thanks to the high-resolution ultrasound and other modern imaging techniques. Thyroid cancer is said to be a unique human neoplasm due to its great prognosis, and it's the only cancer we know where age is one of the most important prognostic factors. For example, we have no such thing as stage 3 or stage 4 cancer, thyroid cancer, in patients below 45 years of age. And last but not least, papillary thyroid carcinoma, our topic for today, is the most common histological subtype. What is our aim in dealing with thyroid nodules? Our aim is to have a balance between minimizing the potential harm from over-treatment of low-risk patients without missing patients at high risk of thyroid cancer. This brings us to an important question. Is lobectomy enough in patients with specific criteria of thyroid cancer? In our search, this question was asked for more than a quarter a century. For example, this case was dated back in October 1993 with the title Lobectomy versus Total Thyroidectomy for Differentiated Carcinoma. And to our surprise, it had a lot to do with our latest guidelines. They mentioned here low-risk patients, that in low-risk patients, total thyroidectomy provides no survival advantage over lobectomy. And it also said that patients presenting with primary tumors of 4 centimeters or less, limited to the thyroid gland, without gross disease in the contralateral lobe and without evidence of metastasis, can be appropriately treated with total lobectomy. However, in 2009, the American Thyroid Association guidelines recommended total thyroidectomy for all well-differentiated thyroid cancers above 1 centimeter. But the question is here, Does the punishment fit the crime, or is it too much? In 2014, a breakthrough study with the title Extent of Surgery for Papillary Thyroid Cancer is Not Associated with Survival was done on 61,775 patients, with the results concluding that the current guidelines, and here referring to the 2009 guidelines that we have just mentioned, suggest total thyroidectomy for all papillary thyroid carcinomas above 1 centimeter. However, we did not observe a survival advantage associated with total thyroidectomy compared to lobectomy. And it also showed similar recurrence and overall survival rates between the two groups, lobectomies and the group which had undergone total thyroidectomy and radioactive iodine. Along with other studies interested in the same topic or the same low-risk group, 1 to 4 centimeter nodule, all had the same result with a 10-year overall survival rate equivalent between lobectomy and total thyroidectomy. This had made the American Thyroid Association modify its latest guidelines and take it down a notch a bit. It stratified the disease into, depending on the rate of risk of recurrence, to a low risk group, intermediate risk, and the high risk, the good, the bad, and the ugly. And now we will talk, our interest is the low risk group. And here is what the 2015 American Thyroid Association strongly recommended. It said that for patients with certain criteria, a solitary tumor between 1 and 4 centimeter without extrathyroidal extension and without clinical evidence of lymph node metastasis, and also with no family history of thyroid cancer and no personal history of external beam radiation, can either undergo a bilateral procedure such as total thyroidectomy or a unilateral procedure such as lobectomy. And they said that the thyroid lobectomy alone might be sufficient initial treatment for low-risk papillary carcinomas. However, the treatment team may choose total thyroidectomy to enable radioactive iodine therapy or to enhance follow-up based upon disease features and patient preferences. And they also came up with this flow chart saying that patients with low-risk group can, the group we just mentioned, can undergo lobectomy. And if the pathological results are the same, lobectomy is enough. If there is any lymphovascular invasion or extrathyroidal extension, or it's an aggressive histological variant, then completion total thyroidectomy is indicated along with radioactive iodine therapy. This has made Kim B. et al. Make an interesting paper in 2016 after the latest guidelines saying that less is more. And less here, he did not only describe less extensive surgeries, he also described less and less use of radioactive iodine in the low risk group. So why is there a debate now? There's a debate between surgeons and surgeons because results in both groups are equally good. And most patients are at low risk with excellent prognosis. So whatever the surgery you do, you can say that I'm doing the best surgery. There's a debate between the surgeons and oncologists because of the role of adjuvant therapy, which is not yet defined in the low risk group. And also the lobectomy group advocates that the complications increase with the extent of surgery, such as hypoparathyroidism, bilateral recurrent laryngeal nerve injury, and bleeding. And also there's a debate because of the patient preference. Our last slide is about a recent study in 2019 made in the Ito hospital. It's the thyroid-only hospital in Japan, when they said the impact of completion thyroidectomy followed by radioactive iodine ablation for patients was studied with lymph node recurrence of papillary thyroid carcinoma. So they followed up the patients who underwent lobectomy alone and are now presented with lymph node recurrence on a unilateral side with no contralateral thyroid nodules. They had the study on 125 patients, 98 of them underwent lymphadenectomy alone, and 27 received lymphadenectomy and completion thyroidectomy, followed by radioactive iodine. and they followed up for a large amount of time, which was 10.2 years. They said that the overall survival and the distant relapse-free survival were not significantly different between the two groups. Moreover, the lobectomy and the completion and lymphadenectomy and radioactive iodine group had significantly longer operation time, higher blood loss, and a higher rate of postoperative hypoparathyroidism. Compared with completion thyroidectomy and lymphadenectomy followed by radioactive iodine alone, they said that lymphadenectomy alone was considered an acceptable therapeutic option, which decreased the surgical disadvantages, but did not decrease survival for at least 10 years after recurrent surgery for papillary thyroid cancer.